Good morning, everybody. At the outset, I would like to thank APO and AIOS Scientific Committee, Dr. Ellen Kumaran, sir. So, today I'll be speaking on do's and don'ts in premium IELTS. We have all seen regarding the trifocal CDOF and difference and this, what are the results of it, like technically and theoretically also. But how to select the patient and what we have to do and what we don't have to do in the premium lenses. First of all, I'll say that after the birth of your child, if most satisfying surgery after it is, I'll say it's a cataract surgery because it's a rewarding surgery as you provide a vision to the patient. Now, coming to the do's and don'ts, we have to divide into the pearls, and we have to. Our basic aim is to convert the premium IELTS and to a refractive surgery, not only to give the vision, but to convert it into a refractive surgery. We have to divide into pre-op pearls, intra-op pearls, and the post-op pearls. Now, pre-op pearls, I'll say choosing a right patient is half battle won. Pre-op pearls, we can acknowledge the need of the patient, where the patient has got a need for near or the intermediate vision. Understand, is there any high level of concern for or a fear for night vision or related issues, as we know that the lenses with the rings will have some problems with it. Make sure that the patient understands that the neural adaptation is a process, and make sure patient has got a realistic expectations. There should be difference between selling versus educating the patient. This is the most important thing. We keep on saying this is the imported lens, and this is so the cost of lens is so much, and this is the Alcon lens. Instead of that, we should educate the patient about the lenses. What are EDOF, what are trifocals, what are monofocals, what is monovision, and everything. Now, preoperative assessment will go for the ocular surface, TFM evaluation, rule out any ocular comorbidities. If at all patient has got any ocular comorbidity, avoid premium lenses in those. Avoid any anisometropic or high myopic or amblyopic patients. Then preoperative refractive surgery patient has undergone, there is increased propensity of glare, halos. There are challenges of power calculation. Recently, we have witnessed for one very big celebrity in Bombay. Now, role of OCT is very important. Being an anti-segment surgeon, you should go for the OCT even if the patient doesn't demand for it, or even if you feel that patient has got no retinal problems. And I'll like to stress that don't shy away to take the opinion of your retinal colleague if you're going for a premium lenses. And this is another important field. I'll say there is too much of information is confusing the patient. Just imagine if you're going for some cardiac angioplasty and the cardiothoracic surgeon tells you you want a medicated stent or a heparin-coated stent, and what you will say is, sir, whatever is best in your hand, just do it. And if you keep on saying all those things to the patient, like what is EDOF, what is asperic, he will get confused and he will land up with the jalebis. Nothing against any parties. Now, measurement of premium IELTS, as Dr. Shehbaz sir has already told, outcome depends on multiple factors because precise preoperative measurements play a very important role. And role of advanced technologies help more for the perfection. Keratometry, we have to measure not only the magnitude but also the axis of the astigmatism. And since new formulas are based on all these things, parameters like axial length, AC depth, and other things, lens position, we have to take into consideration. So the result, the point important for us is use the optical biometry according to your pocket budget. But still, I'll say even if you want to go for premium lenses, you should go for the optical biometry. Because already the previous speakers have spoken about it, like ablation, there is an error of 0.24 millimeter, and the least error is, I'll say, the optical biometry. Then appropriate formulas based on the axial length are very important, but nowadays Barrett Universal 2 is acceptable for most of the range of axial lengths. This is another important thing I use usually in my practice, that is triangle of agreement. I usually take 2 or 3 formulas and I use best out of 2. And if the patient has got severe astigmatism, I go for the topography also, and at least we know what is the steep axis and a flat axis. Then astigmatism in the premium IELTS, I'll say that preoperative corneal astigmatism, if it is more than less one diopter, I'll go for multifocal or EDOF lenses. If it is more than 1 to 2.5, I'll go for multifocal toric or the toric monofocal lenses. But if it is more than 2.5, usually I avoid EDOF, toric, or any lenses with the rings. Astigmatism, we have to take into consideration total astigmatism. Nowadays, it is not like desirable only to consider the anterior corneal astigmatism. You have to see for the posterior corneal astigmatism and also your SIA. Because if you don't consider it, if the patient is having with the rule astigmatism, we may overcorrect it by 0.5 diopters. If it is ATR, then we may undercorrect the patient by 0.30. IOL tends to center on the limbal center and not on the visual axis. So if the large angle kappa, we may have dissatisfaction of the patient in means of halos or the patient's poor satisfaction. Better option for such patient would be monofocal vision. And if you can afford, if you have got some such machines, if the patient has got higher order aberrations, you can use eye trace. Then needless to say, intraoperative pulse, like your incision should be perfect, rexis should be perfect. Nucleotomy, I'll say, even if the cataract is grade 2, if your patient is paying so much, use viscoat if you are in doubt for the poor cornea. And eye stability is one of the most important part. Eye centration, I like to add with the along with the previous speakers, you have to see the Purkinje images 1, 2 and 3. Purkinje image 1, where the bottom down, it is on the anterior surface of the cornea. Purkinje image 2, we cannot see on the posterior surface of the cornea. Purkinje image P3, it is on the anterior surface of the lens, it is just the reflection on the lens. And P4 is the Purkinje image 4 with the base upwards. So we have to coincide after the surgery P1 and P4 image for the proper centration of the lens. Now just guess, even after doing so much of gymnastic, patient may have poor satisfaction. So I'll say there are 6 C's for the poor satisfaction or unhappy patients, like poor cornea or ocular surface disease, cylindrical or residual refractive error, some capsular opacities, look for cystoid macular edema or other macular degeneration problems, check centration of the lens, or most of the point type A behavior patient like crazy patients. Leave those patients. Now negative dysphotopsia, especially when the pencil of rays comes from the periphery and the edge of the shadow lands up and we give the shadow effect on the retina, patient may complain about negative dysphotopsia, but in my practice I have seen after 2 or 3 months the patient get used to it, so we don't have to worry much about it. These are the positive dysphotopic phenomena usually we see in the multifocal lenses with the rings. Neural adaptation is just like your spouse, because it is both the problem and the solution. So the acquired process by which the nervous system adjusts changes to the neural inputs. The time taken is 3 to 1 year. So I'll say, if you can understand the Hindi, sir, खुद ही को कहते थे मुझे खुद को बदल लो, और अब बदला हो तो कह रहे कि वो न रहे तुम. This is just like your neural adaptation. So rotational stability, as the IOL rotates by 3.3%, we lose the cylindrical astigmatism of the cornea more than, if it is more than 30%. Any disparity in the toric IOLs, you should, again you can go for fixing the problem with the www.astigmatismfix.com and we can realign the IOL. To summarize, start with the hypermetro female patients, know the patient's occupation very well, counsel the patient about halos and glare, especially with the multifocal lenses, precise IOL power calculation. The multifocal and toric lenses are very sensitive for the residual refractive error. Use newer generation formulas like universal Barrett 2 formulas. Avoid ocular extreme axial length or virial keratometries. Just straight away tell them that we want to, these lenses are not suitable for you, go for the monofocal lenses. And promise less and deliver more, otherwise this will happen. You may tell that I'll get more than 400 seats and you get only 288. Again, nothing against any party. Promise less and deliver more. And just imagine, after doing all the gymnastics, you land up with a patient having the glasses. I'll say few patients are there which we know are pseudophakic and wearing glasses and still they are happy. So nothing to worry about it. Go and use premium lenses in your practice. Thanks a lot. Thank you very much, sir.
Thank you, Dr. Subodh. Wonderfully put. Most of the points clearly explained. I think key takeaways, taking a history and understanding the need of the patient more important than all the technology that we have.